Good morning. Welcome to the Buck Institute for Research on Aging. My name is Dr. Susan Gross, and I'm a sports medicine physician at the Sanderfeld Medical Center. I'm also a member of ConcussionSmart Marin, and I am one of your course directors here this morning. I want to thank everybody, as well as all the members of ConcussionSmart Marin who worked so hard to put this symposium together. A little bit of housekeeping before I introduce our moderators. So if you haven't figured out where the bathrooms are, they are across the atrium. If you are planning on applying for CME and you did the questionnaire that was emailed to you, thank you. If you did not, we do have some paper copies of the questionnaire, and then you'll get a SurveyMonkey survey to follow up. We'll have a 10-minute break, and breakfast will be provided until 10, but the Buck Institute does ask that people don't bring any food or beverages here into the auditorium except for water. I wanted to start out by telling you guys a story. So I was born and raised here in Marin County. I went to high school at Redwood High School, but I did my medical training in both medical school residency and fellowship in Alabama. And when I was a third-year medical student doing my clinical rotations, one of my friends was a fourth year doing a rotation in neurosurgery. When my friend was in the OR one day with his attending, midway through the procedure, his attending pointed to a structure in the brain and he said, "Dr. Brunsvold, what is this?" And my friend thought about it for a minute. The room got very quiet, and finally he said, "Well, sir, that would be the mind." Our attending was not pleased. And you'll be relieved to hear that Dr. Brunsvold is not a neurosurgeon, he is a practicing psychiatrist. But I tell that story because it really does get to the heart of the matter. Because an injury to the brain is an injury to the mind. There's really no other injury that strikes at the heart of who we are. And to make matters worse, it's invisible. It doesn't show up on regular imaging like CT scans and MRIs. There's no blood test like a troponin that we can do to see if an injury has occurred. We don't really have the kind of evidence that we'd like to have. We have expert opinion and consensus guidelines, the last of which came out just this last Friday out of the Berlin conference. It's a truly daunting thing to have to try and manage. And for our children, it's an injury to their organ of learning. So what are we supposed to do in this kind of a situation? Luckily, taking care of concussions is really a team effort. And the quarterback of the team is clearly the primary care physician, the pediatrician or family medicine doctor who really knows the patient the best. But you're not alone. Every high school in Marin County has certified athletic trainers now, and along with our school nurses, guidance counselors, the primary care physician has a good team for the bulk of the patients who get better within about 4 weeks if they're a teenager. There are a significant portion of our children, however, do not. And that's when you need to bring in your secondary. So neuropsychologists, psychiatry, vestibular therapy out of physical therapy or occupational therapy, and vision therapy with our neurooptometrists. These are just some of the modalities that you can use to help your patients. And hopefully by the end of this morning, you'll feel like it's not a problem for you. And you know where to go and who your team is. Before I introduce our moderators, I want to tell you guys one more story, if I can figure out how to work this. People ask me all the time if I would let my kid play. And my answer, because I have to answer truthfully, is to say, well, yes, I did let my kid play. My son Michael played football for 4 years. He never got a concussion. He did tear his ACL twice, but that's a story for a different symposium. But I have 2 daughters as well, and my daughter Nayla, on the other photo, is a soccer player. Nayla, as a freshman, was playing varsity soccer, and one day when I was at work, I got a phone call in the preseason from Nayla, and she said, "Mom, I think I have a concussion." Now, I only work about 15 minutes away from the school, so I hopped in my car, and 5 minutes later when I got there, she was sitting next to the athletic director, and he proceeded to regale me with a story about how she went up for a header, and one of her teammates, who's bigger and taller, went up for a header at the same time, and her teammate headed the ball and drove her forehead into the back of my daughter's skull. Both girls fell on the ground. Her teammate had a facial laceration, so she was covered in blood, and everybody was very focused on her and got her packed up and sent her to the emergency room. My daughter got up and walked to the bench, And when her coach said, "Can you go back in?" she said, "Sure." But she knew that something was wrong. And so at the half, she called me up, and I got out there, and after the athletic director told me the story, I asked her to stand up, put her hands on her hips, and close her eyes. And she fell over. Walking to the car, she weaved like a drunken person. She had a headache, she had nausea, she had dizziness, she had light sensitivity. She was incredibly slow to respond to questions. The next morning, when I asked her if she wanted a bagel or a waffle, she just stared at me and finally wrinkled up her forehead and said, "I don't understand what you're saying." She couldn't read, and this is a kid who reads for pleasure. So the story does have a happy ending. Under the expert guidance of her pediatrician, she was able to return to school within 2 to 3 weeks. At 4 weeks, she was able to return to play. And this year, as a junior, her weighted GPA is 4.85, and she made the all-league team the second year in a row. But that's not the happy ending I'm talking about. The happy ending I'm talking about is earlier this season, in the midst of a game against their arch rivals, which is always a dogfight, she was in the back playing center defender, and she headed a very hard-struck ball out of the goal. And then the opposing team's goalie kicked the ball really hard, and she headed it again. And then I saw her trot over to the sideline and look at her coach and say, "Hey, coach, I think I need to come out and get checked out." And he subbed her out, and she was checked out, and she was fine and returned to the game. And they lost the game, but the thing that really struck me was how my daughter had the information available to know whether or not she might not have been okay. And she had the confidence and was participating in a culture where it was okay for her to step out because she knew that the outcome of that game was not as important as what would happen to her brain. And that's really the destination that we want to see for all children in Marin County, not just the doctor's kids. So I'm really happy that everybody's here today because I think that working together we can all make that a reality. I'd like to introduce my two moderators today. Mary Jane Burke. Mary Jane is superintendent of the Marin County School System. She was elected in 1994 and has been at the forefront of measures to help our children as a teacher, as a principal, as a deputy superintendent, and now as a superintendent. She's a founding member of ConcussionSmart Marin and lends her considerable expertise to our efforts. And Tagaloa, thank you, has lived in Marin County since he was 2 years old. He's a product of the Marin County school system. He was a 4-sport letterman at San Rafael High and went on to play for UC Berkeley. He then graduated and played for 6 years in the NFL for the Oilers, the Bengals, the Seahawks, and the Saints as a defensive lineman. Please join me in welcoming two of Marin County's finest.
So I too thank all of you for being here, all that have partnered to make this amazing opportunity come together. You have the opportunity to hear 9 amazing people over the next period of time. If you can imagine, this is sort of going to be like a TED Talk, right? So we're going to have a very important job to keep this moving. And in advance, we thank each of our speakers for being here this morning. Natu.
Thank you, Mary Jane. Thank you, Susan. I appreciate the stories. They bring back some painful memories, but you're finishing off with the changing culture as an inspiration, so thank you so much. Before we introduce our first presenter, this is also very personal for Mary Jane and myself. Mary Jane has 2 grandsons that have a lot of promise in athletes, and presently I have 3 daughters, one that's gone through the public schools and graduated from college playing volleyball, and 2 others that are playing volleyball and basketball. So we know that we want to protect our kids. And for those that don't know, currently boys baseball and girls volleyball have the most significant increase in the rate of concussion during a 10-year study by the American Academy of Orthopedic Surgeons. So we're standing here as parents and grandparents who want to ensure brain health for all children. Our first speaker is Dr. Richard Delmonico, who is the Chief Neuropsychologist at Kaiser Foundation Rehabilitation Center in Vallejo and oversees all of neuropsychology departments in all of Kaiser Permanente in Northern California. He is also an associate clinical professor at UC Davis School of Medicine. His educational, administrative, professional affiliations are endless, and he has been published extensively. Today, he will speak to you about pathopsychology of concussions. Please welcome Dr. Delmonico.
Can everybody see that? Let me try this. Is that a little brighter? Good morning. So we're going to be talking about concussion this morning, and what I'm going to try to do is explain the pathophysiology of concussion. I don't have any disclosures. Is there some way to get the screen larger? Great, thanks. Okay. It needs to be moved. It's off the screen. Yeah, it was off the, it was moved over, so, okay. Let's try this again. Okay, here we go. So what you're going to hear about this morning over and over and over again is the symptoms of concussion. And that's really the only real thing that we can hang our hats on that indicates to us whether or not the individual actually had a concussion. One of the problems with the symptoms is that there are many studies that have shown that the post-concussive symptoms can be endorsed by a variety of people, people with depression, people with anxiety, people with chronic pain. So although the symptoms are helpful in describing to us actually what's happened, many other individuals with a variety of medical problems report similar symptoms. So I've broken them down into larger categories because I'm going to relate the pathophysiology to the actual behavioral, cognitive, and physical symptoms for you. So this is a list of the cognitive symptoms. The most common are what Susan described: memory problems, concentration problems, slow processing, kind of confusion. These are the physical problems. Smell and taste changes, noise and light sensitivity are very common, along with ocular, motor, and vestibular problems that we're going to hear about later this morning, visual disturbances, poor coordination, poor balance, dizziness, and more importantly, sleep disturbance. The emotional symptoms that we see are irritability, anxiety, poor frustration tolerance, feeling overwhelmed, as your daughter described. She just felt like she couldn't understand what you were saying in the morning. And impatience, impulsivity, demanding. So what happens? Well, we know from animal and human studies, primarily out of the earlier studies were by Giza and Havda out of UCLA. What we see is an initial phase where there's an initial depolarization, and there's an outpouring of potassium and an influx of calcium and a release of glutamate. Then the sodium-potassium pump tries to restore the equilibrium. So what happens as a result of that is that energy, it uses up more energy by the cells. So there's an increasing demand for ATP, which basically carries energy to cells. And that triggers a jump in glucose metabolism, which in turn causes a hypermetabolic state. So the increased demand for energy, combined with the decreased cerebral blood flow, which happens after an injury, and decreased intracellular energy supply, leads to what we call an energy crisis. And you'll hear that over and over and over again, about the energy crisis that happens after a brain injury. So this is just a graphic representation. So here's the potassium and calcium. And calcium also impairs the cell's ability to produce ATP, which is an energy source for cells. So that worsens the energy crisis. Okay, then there's a period of depressed metabolism. So the next phase involves this persistent increase in calcium, which impairs mitochondria, which mitochondria produce ATP, energy for cells. So what's happening? The energy supply is going down, and the brain wants to use more energy. So this energy crisis continues. In addition, this can cause permeability of the blood-brain barrier and cerebral edema and swelling of the brain. And unchecked, the calcium accumulates in activated pathways and can cause cell death. In addition, it causes impaired neural transmission. Other things that are going on are generation of lactic acid, and that makes individuals vulnerable to secondary ischemic injury, increased intracellular magnesium. Magnesium decreases, and that can last for days after an injury, and that's correlated with neurological deficits. And magnesium is essential for ATP. So what do we see? We see all these symptoms acting on ATP, which is an energy source. The cells need more energy, and the energy supply is going down. There's also an inflammatory response and obviously altered neurotransmission. So here's another example of what's going on, and you'll have all of these in your slides. This slide I threw in as a reference for all of you. This is kind of a busy slide, and this is essentially a more detailed example of what I've already shown you. So what happens here? This is a graphic representation. So this is days following the injury. And I think the most important things that you can see here are the increase in potassium and calcium, glutamate, and yet glucose, which we know the body needs to repair itself, is going down up to 7 to 10 days. But as Susan said, one of the important things to remember is that this may be going on at the kind of the physiological cellular level, but we're running a sports concussion clinic in Vacaville, and what we have in Kaiser Vacaville, and what we have found is that most of these kids take about 3 or 4 weeks to get better and back to sport over time. It used to be said that 7 to 10 days they should be normal. We're not really seeing that. We're seeing 3 to 4 weeks actually. And then this is cerebral blood flow, also decreases. So what's happening here? So shortly after a concussion, cerebral blood flow decreases and delivery of fuel or energy decreases, and it's prolonged for 7 to 10 days. There's this metabolic mismatch, high metabolic demand versus decreased energy availability. And this energy crisis actually increases vulnerability to greater severity after a repeat concussion, and I'm going to talk about that in a minute. It's called second impact syndrome, and I'm sure you've seen that in the news and in newspapers and magazines. And then there are structural changes with the integrity of axons, which carry the information from one nerve cell to another. So how does all of this relate to those symptoms that we were looking at earlier? Well, that ionic flux that I described in the beginning, the efflux of potassium and the influx of calcium, we know, looking at migraine headaches, that individuals with a family of migraine history have some of this similar thing going on. So we believe that actually that relates to the migraines and some of the headaches that we see after a concussion. In addition, this relates to light and noise sensitivity. The energy crisis makes individuals vulnerable to a second impact injury. And these structural changes and changes in neurotransmission, we believe, are related to the cognitive symptoms, the decreased processing, decreased reaction time, and cognition. And that's actually what the computerized neurocognitive tests for sports concussion measures like the impact. That's what the impact looks at, is information processing speed, reaction time, memory, and attention. So what other areas do we know are affected by an injury? Well, the vestibular system, and there are two primary systems, the vestibular ocular system and the vestibulospinal system, and that relates to the poor balance and dizziness and visual instability. And then the ocular motor system, which we're going to hear about in detail later this morning. What's important to know about these two systems is the vestibular and ocular motor disruption can delay recovery. So in our clinic in Vacaville, we've had kids who have come in 3 weeks after their concussion, 4 weeks after their concussion. They have balance problems, ocular motor problems, which make it very difficult to work in school because everything is on a computer in school these days. So they have a lot of difficulty processing that visual information. What we've seen is that these kids that come in with this delayed recovery, when we refer them to a vestibular PT who also works on ocular motor functioning, they improve fairly quickly. And those symptoms can delay recovery considerably. The other thing to think about today is the other thing that delays recovery is screen time. Phone, TV, computer, tablet. It isn't uncommon to see kids come into the clinic and they're using their phone or tablet or computer 4-5 hours a day, and they're not getting any better. And what we've found is that when you decrease that to less than an hour a day, and believe me, that's very, very difficult for them and very difficult for the parents to get them to do that, they improve. So what else do we know? Well, as Susan said this morning, there aren't any physical tests that we can really do. We're working on research on blood tests. These are all serum tests, and none of these have really been able to distinguish between someone with a concussion or a mild TBI and no TBI. This measure right here, this S100B, this has been used in moderate to severe brain injury, and what it seems to correlate with is levels increase with increased brain damage. So we know people with subdurals and contusions that S100B increases. The problem is this is also increased in athletes without brain injuries. So none of these are ready for prime time. So what about a CT? Everybody thinks that, well, should they have a CT scan? They're in the ER, they've had a brain injury. What do we do? CTs are not routinely ordered because they're not very useful. For example, if you look at individuals with moderate to severe brain injuries, often a CT can be normal. Contusions don't always show up on a CT. Subdurals usually do. But if they don't have a subdural or a contusion, usually the brain looks pretty normal. You may see some edema, but that's about all you see. The CDC is recommending brain CTs with any individuals who present with these symptoms. Or obviously, if for some reason during your clinical exam you think they may have a more severe injury than an uncomplicated sports concussion. So second impact syndrome. What is it? Well, it's controversial and it's rare, but when it happens, you read about it in the newspapers. It's very devastating. It's on the news. So what is it? Well, there's an initial concussion, and you've seen what the neurometabolic changes are. And this sets the stage for vulnerability. Second impact is when the individual is still going through this neurometabolic change and they have a second injury, which is often a milder injury than the initial injury. And what happens is that the vulnerable brain has difficulties compensating for the second injury. So there's an increase in intracranial pressure. It can lead to diffuse edema, herniation, rapid decline, and death. So how do you manage these? Well, one of the most important things is, as I said, if you suspect a more serious injury, do a CT or an MRI and immediately stabilize the individual and get a neurosurgery consult, obviously. So how can we prevent these? Well, one way is to make sure that you don't return kids to play when they still have symptoms. So that's one of the reasons why we have these new laws, is so these kids aren't returning to sport without being cleared by a health professional. Yes?
The age group that you worry about this with, and why is that?
It can occur at any age.
More common in teens?
Yes. Because that neurometabolic cascade can happen in adults, kids, that's across the board. So, CTE, we've all read about it. We all know something about it. It's all over the news. The NFL is looking into this. There's a lot of research on this. So, what do we know about CTE? Those of us that have kids, we're concerned. If they have multiple concussions, are they going to develop CTE? And there are some case studies of individuals 25 years old that have had it on autopsy. What do we know about this? It's a neurodegenerative condition that results from repetitive head trauma. It's characterized by tau deposition, but it's only noted post-mortem. It can't be diagnosed in a living individual. What are the problems with the studies? Well, one of the main problems is sampling bias and lack of controls. And the pathology is seen in non-symptomatic cases. And the pathology overlaps significantly with other types of conditions, other types of dementia. The clinical descriptions that we read about in the paper are varied quite a bit and overlap with a lot of other conditions. So this is one of the reasons why we're having difficulty kind of figuring out what's going on with CTE. But the conclusion that you can make is that we don't know, but multiple blows to the head are a problem. And how many concussions somebody can sustain before you need to retire them is not a question we can answer at this point. It's a judgment call. These are some useful references that are in your packet. This is a new research review on CTE. This article by Collins from 2013, I think if you haven't read anything on sports concussion, this is a place to start. They talk about trajectories, they talk about symptoms, they talk about how to treat these cases. And then these are some resources from the CDC. This is a report, this pediatric mild TBI work group report just came out, I believe it was in July. And in this document from the CDC on returning to school, this is a wonderful resource. So I would suggest you all look at that online. Are there any other questions? Yeah.
Yeah, there's a lot more information on CTE. I'm one of the original, I'm a former NFL player,
Mm-hmm.
president of the NFL alumni in California, and there's a lot of information. It's done at Boston University under Dr. Ann McKee and also with Dr. Stern. And the statistics show that 95% of the players that play in the National Football League will have CTE in their brain when they die and they do an autopsy. And it's also becoming, they're finding that second impact syndrome is very critical right now, especially in high school sports, and especially in girls' high school soccer, where there are more concussions in girls' high school soccer than there are in boys' high school football. And the key to this whole thing, when you do or do not have a doctor on the sideline, other than what you can see visually, is being able to tell what the magnitude of the impact was so that you can make an informed decision as to whether or not that child should return to play. Because the second hit is what's known as
Thank you. Yeah.
There's technology out there that'll show you that right now. There are two chemists from Michigan State University that developed a product, a headband, that will tell you what the magnitude of the impact is. It will tell you whether it was mild or severe, so that on the field, whether you're a trainer or you're a doctor or a coach, you can make an informed decision. It's a data point on that.
There's also another test that's being developed with ocular motor tracking. It's called eye track, that actually is pretty sensitive too.
Yeah, well, some of them are electronic. It's
Yeah.
based on chemistry.
Yeah.
But I was one of the original 22 guys in the NFL who sued successfully the owners. And this has become a passion for me.
Mhm.
Knowing as much as I can about it.
Thank you.
Sure. So at this time, if we could give a round of applause for Dr. Delmonico. Very much. Just to give a little bit of background, as a reminder, I think everyone's aware that this entire session is being documented, so will be available for those of us in Marin and beyond. And there will be opportunities for anyone who has any particular questions that you want to be sure are answered, that we'll be able to accept those questions, and we'll be developing a Q&A for our community. So at this point, if I could please ask Dr. Jean Marie Sinnett to come forward. There she is. And as she's walking up, I want you to know that Dr. Sinnett is a family and sports medicine physician at Kaiser Permanente in San Rafael. Thank you very much for being here. An athlete herself, including alpine skiing, triathlon, swimming, cycling, mountain biking, is also an experienced team physician and published. She's been published as well. She'll be speaking on sideline assessment of concussions. Thank you very much.
Thank you. Thanks. Okay, so I did a sports medicine fellowship. I've spent a lot of time on the sidelines of football, soccer, volleyball, ice hockey, basketball. All these sports have a lot of concussions, and so I've done a lot of these sideline evals and seen a lot of people in the office with concussions. So just going to talk a little bit about what we look for on the sidelines. One of the things in the recent Berlin consensus was that they made a point to say there's no perfect diagnostic test, there's no typical symptom, no typical presentation, and so this stuff is kind of a judgment call a lot of the time. But these are some of the things that we'll do frequently on the sideline in kids that take a hard hit and might have a concussion. So some of my objectives. And okay, so first thing is this all starts before the season even begins. Preparation for taking care of concussed athletes begins with a pre-participation exam and developing an emergency action plan. So this is something that the whole team has to agree on, the athletic trainers and doctors and coaches and everyone. You want to, evaluate each athlete with their concussion history, anything that could be playing into their symptoms if they have a mood disorder, a learning disorder, migraines, baseline symptom score. So a lot of these kids might not have a baseline symptom score of 0. If they get migraines every week and have anxiety and depression, their symptom score is not going to be normal, but it might be their baseline. Balance testing, I'll talk about this more later, but you want to ideally get this in game time conditions. You want to get them on the field in their cleats, kind of wearing all their sporting gear in a game time environment at the end of practice. And that'll kind of give you the best replicate of what you're going to want to look for on the sideline of a game. There's SCAT, NFL Sideline Concussion Assessment Tool, are a couple of the kind of standardized tools we'll use, and neuropsych testing. So that's the impact, cog state, and these are computerized tests that can be done in the office. I think we'll hear more about them this morning. Know your athletes. So athletic trainers are huge here. They're with the athletes every day at practice. Coaches, same thing. They know the athletes a lot better than team physicians who show up on Friday nights to cover a football game. Parents obviously know their kids the best and are crucial sometimes in noticing those subtle changes in behaviors and performance that the team physicians might not be able to recognize. So, no typical mechanism. It might be a direct blow to the head. It might not. It might be a blow to the body that transmits force to the head. Sometimes, acceleration, deceleration, shearing forces, rotational forces. They've identified some high-risk mechanisms. A double hit, so that's where, they get hit in the head once by, say, another player, and then they hit the ground, or they hit someone's shoulder and then another player's helmet, kind of in the same play. And then trauma with shearing force from a rotation. So they get spun up in the air and then they land on the ground. And then a second hit. So this is not the same as second impact syndrome like we heard of before, but they get hit once in the beginning of the game and then, half an hour later they get hit again. It kind of lowers the threshold for injury to the brain. And they've done accelerometer studies. They've tried to identify what force does it take to cause a concussion, and they haven't been able to find anything. I mean, linear acceleration over 100 Gs might be more risky for concussion. Rotational acceleration over 5,500 meters per second, maybe. But, people will have acceleration way above these and be fine, and other players will have a concussion with much less. So it's still kind of up in the air. So from the sidelines, not all concussions need to go to the ER, most don't. But if they're having seizures, extreme drowsiness, profuse vomiting, slurred speech, progressive confusion, focal neurodeficits, weakness, numbness, neck pain, you want to rule out cervical spine injury. Changing level of consciousness, just kind of going downhill fast. And loss of consciousness over a minute. This is kind of a question mark here. 10% of concussions have loss of consciousness, and that has no effect on their prognosis or severity. If they're out for more than a minute, that's sort of a little more of a concern than, if they're out for 10 seconds, and so you might send that athlete to the ER, but that still doesn't necessarily mean anything in the long run. There's a couple of these pocket concussion recognition tools. So this one's created by FIFA and the Olympic Committee, and just sort of something, little pocket cards that can be carried around to it shows the red flags and typical symptoms, gives you some questions to ask. There's apps on cell phone apps that parents a lot of times will download, and if they're concerned, they'll pull out their app and take a look. So just to outline what we'll do on the sideline, any injury obviously starts with ABCs. You want to rule out serious brain injury, know when to transfer to the ER, and then our assessment. So we'll start with symptoms, memory, cognition, quick neuro exam, balance testing, oculomotor, vision testing, and coordination. And then, maybe if you're thinking of sending the kid back in, if they're fine, you want to do some exertional testing, get them running, see how they do. And an important thing with this standardized, or this, concussion sideline assessment is it has to be standardized. Everyone has to agree in advance what they're going to do, sort of create an emergency action plan, because it's chaos out there. I mean, there's a lot going on, and you have to just be able to get the kid on the sideline, go through your steps, and decide what you're going to do. So first scenario is athletes down on the field. Trainer and doctor run out there. So airway, breathing, circulation. And then if they're, having any neck pain, you want to rule out cervical spine injury. So that's, if you find that, immobilize the neck, get them to the ER. Same thing with any neuro deficits. If you're worried about a brain bleed or serious brain injury, transfer to the ER. If not, you exclude all that. You want to safely get them to the sideline and start your assessment. So, but more commonly what happens is an athlete takes a hard hit, they finish the play, they come off the field, and then they go up to the coach or trainer or call their parent or talk to someone and say, hey, I think, I'm not feeling right. So that's what more commonly happens, and that should prompt a sideline evaluation. So we heard about the four sort of kinds of symptoms: physical, cognitive, sleep, and emotional. Mainly on the sideline, so physical symptoms, headache and dizziness are the top two. And dizziness is important because, especially in high school players, it's actually found to be, if there's dizziness at time of injury, that they're more likely to have a recovery lasting over 21 days than if they just have headache at time of injury. So nausea, vomiting, not being coordinated, balance problems, vision changes, Sometimes they lose vision temporarily, blurry vision, double vision, seeing stars, light and noise sensitivity, just looking kind of dazed, like not knowing what's going on. Cognitive symptoms, so they're foggy, you're talking to them, they're not really acting right. I can't remember what happened, forgetful, repeating questions. So, I mean, at this point, if you're in doubt, sit them out. That's kind of the mantra. When in doubt, sit them out. The consensus guidelines, they all say any athlete suspected of having a concussion should be removed from play and assessed by a licensed healthcare provider trained in the evaluation and management of concussion. And if no one's available, if there's no provider available, then you sit them out and they don't return to play at all on that same day. So that's kind of the main important thing to remember here. Gross exam, so you're evaluating them on the sideline, they just don't, they don't look right, they're out of it, get them talking, like, tell me what happened, talk to me. They might look okay standing there, but you get them talking and they're not really following the conversation, they can't really explain what happened, acting slow. And then we have this cognitive assessment, these Maddox questions. So the typical orientation questions, person, place, and time, those have been found not to be effective at all in evaluating concussion, but the Maddox questions are a little better. So where are we today? So like what school are we at? What field? What half is it? Who scored last? What team did we play last? And did we win our last game? So a couple things about Maddox questions. One is, obviously you modify it for the sport you're in, so half, period, quarter, inning, whatever sport. And then the examiner has to know the answers to these questions. And it sounds funny, but any well-meaning doctor that volunteers for a football game and shows up and has no idea what's going on with the team, pulls out their card and asks these questions, doesn't know if the kid's right or wrong. So this is, if you're gonna ask these questions, you gotta know the answers. Physical exam, so we're gonna do a quick cranial nerve exam, strength and sensation of the extremities. Mainly we're looking for any focal neurologic deficit, any obvious sign that there might be more than a concussion going on. Do some vision tracking, ocular pursuits, horizontal and vertical eye movement. We'll hear more about this part of the exam later today. Gaze stability, accommodation, convergence. And so one thing about the vestibular and ocular motor testing is it can elicit symptoms that might not be otherwise apparent. So it can make them nauseous, it can make them dizzy, and they'll progressively become more and more symptomatic the more you test them. So this kind of stuff is best to be done sort of at the end of your exam, because when everything else has been normal so far, normal memory, normal neuro exam, this might elicit symptoms when nothing else has. And coordination, so we'll just kind of do a quick finger to nose on each side 5 times. And balance testing. So this is the close your eyes, put your hands on your hips. There's 3 parts to it. It's called BESS, Balance Error Scoring System. So there's this is something that basically it's worse in the acute period. So when they first get hit and for the first 3 days following a concussion, but then it tends to get better after that. So it's a good sideline test, but not great for tracking when you're following them in the office. And so the 3 stances, there's hands on your hips, hands on your hips with your one leg up, and then a tandem stance, and eyes closed. And it's actually pretty hard. You want to hold each for 10 seconds, or 20 seconds, and you take a point off for each error. So there's a list of things that'll cause an error: opening their eyes, putting their foot down, moving their hands, moving their leg. And so this is where baseline testing is extremely important. The average number of errors for the when you add up all 3 stances, 20 seconds each, is 10 errors for a non-concussed person. So 17 errors for concussed athletes and 10 for a non-concussed. And if you can imagine, if you're doing this on a football field in cleats, wearing a like pads and there's a game going on behind you, it's harder than if you're in a training room on a flat floor barefoot. So that's why you want to test this ideally pre-season, like at the end of a practice when they're tired and there's kids yelling and they're in their, their gear. So, King de Vic test is a vision test. It's based on naming random numbers that kind of capture impairments in eye movements, attention, language, and this might correlate with suboptimal brain functioning. So it's good because it takes 2 minutes, anyone can administer it. It's valid starting at age 5. It's a rapid sideline screening test for concussion. And if your score worsens from baseline, then that means you're 5 times more likely to have a concussion. It aids in the diagnosis of unwitnessed concussion, I guess, if you didn't really see what happened, but you want to see how their function is. But you need a baseline, because this is going to be different on everyone. So it's a tablet app. You can store all the kids on the team, store their baseline, and then you just pull up their name and repeat the test on the sideline. And this is what it looks like. So you read left to right, you read the numbers. Each one gets harder when there's no arrows, and basically you just have them read it and subtract the errors and time how long it takes. And then SCAT, so this is another tool. There's a lot of, they're on the 5th one. It actually just came out last week with the Berlin consensus guidelines. So it basically puts together everything I just talked about. So there's the symptoms, the red flags. It goes a little more into memory and concentration. So it has you do digits backwards, repeating the words. It asks you at the end of the test to repeat the words that you heard 5 minutes ago. So it's kind of like it's kind of like a memory test, and this is something that can be done as a baseline on everyone at the beginning of the season, and then if they had a concussion or you think they had a concussion, it can be done in the training room or the next day to see how bad it is. And so, the recent consensus says that SCAT-5 currently represents the most well-established and rigorously developed instrument available for sideline assessment. But this utility decreases like 3 to 5 days after injury, so you're not going to be doing a SCAT at every concussion follow-up. The symptom score is helpful to track their progress, but the whole, cognitive screening and memory and all that is really more of an acute thing. So, say they took a hard hit, they didn't look right at first, but now they're feeling better, they're asymptomatic, they got through their whole sideline assessment, everything was normal. You might put them back in. If so, you want to do something exertional, have them sprint, cuts, figure eights, high knees, push-ups, get them sweating, get their heart rate up for a couple of minutes, and ask them how they feel. If they still feel okay, then maybe they can go back in. I would say in youth sports, we're probably less likely to do this. If you have enough concern to do a whole sideline assessment test, you probably just want to keep them out. But, in college and pro sports, this is definitely stuff they would do if everything turns out okay when they do their sideline assessment. But always remember, when in doubt, sit them out. And that's my references. So. Yeah.
Hi, you said something really interesting. I thought that you said when at the time of concussion, if they have dizziness, they're more likely to take 21 days to recover.
Mm-hmm.
Is that 21 days to recover to go back to school or go back to play or complete recovery? What does that mean?
So complete recovery, yeah. It's common in youth sports for it to take 3 to 4 weeks, but some kids will take 7 to 10 days, and some will take a lot longer, some will take months. And that dizziness at time of injury has just been found to be a predictor of more long-term recovery. So.
Is it prolonged? Will you see that in the office, or is that just at the time of injury?
A lot of times you will, but just the dizziness at the time of injury is kind of a poor predictor. Yeah, but a lot of them will continue to have dizziness as a symptom. Yeah. Mm-hmm.
Do you use any neurofeedback or biofeedback tools for doing your baseline assessment?
What sort of tools?
Neurofield, clarity,
Mainly for the preseason. I mean, there's impact, scat, the best testing, but I'm not sure if I'd. Mm-mm. Mm-hmm. Thanks. Yeah. Yeah. It makes it hard. I mean, sometimes they're not symptomatic at first, and then they go home and the next morning don't feel good, and then they had a concussion, but they kept playing. So, I mean, one thing is some of these balance testing and visual testings and oculomotor, tracking tests can elicit symptoms that might not otherwise be apparent. So if you suspect a concussion, if they took a really hard hit and took kind of a while getting up, and you want to assess them, those are some things that can bring on symptoms that might not otherwise be apparent. And the other nice thing about the balance and the vision testing is it's a good way to convince the athlete and the parent that they had a concussion, because a lot of times people are reluctant to kind of sit out and have their kids sit out, and they do this whole memory test and all your neuro stuff, and it's normal, and then you have them close their eyes and stand on one leg, and like you said, they fall over, and you're kind of like, well, see, you're not, your brain's not working. Or the vision, it takes them 5 minutes to get through that chart, or makes them nauseous, then that can convince them that something's going on. So, I mean, there's always cases where they don't have symptoms, and then the next morning they do, and that's what makes it hard, but I guess we do the best you can. So.
That's been our experience too. That, kids will come into the clinic 3 weeks later.
Yeah.
And they're coming in to be cleared, and we do the balance and oculomotor testing, and they're falling over. And it's useful with parents to explain, no.
Yeah.
You can't go back.
Yeah. Yeah, you can't play when you can't balance on one leg, so yeah. Okay.
Thank you, Dr. Sinnett. We'll always remember your advice when someone says, "Put me in, coach." We're very fortunate to have our next presenter, Dr. David Goltz. Dr. Goltz is a board-certified orthopedic surgeon who practices at the Mount Tam Orthopedic Medical Center and a former chief of orthopedic surgery at Marin General Hospital. Dr. Goltz is also an athlete and is head team physician for the U.S. Olympic freestyle ski team since 2011. He has also been the head team physician for Dominican University, Redwood High School football, and the Tam Union Rugby Club, and is a certified impact consultant. Dr. Goltz has received many honors and is also well published. Today, Dr. Goltz is speaking to us about sport concussion office management. Welcome.
Thanks so much. I feel really privileged to be able to speak to y'all. As an orthopedic surgeon, I am probably the least likely to be considered an expert on concussion. So I thought I'd introduce myself. I am a sports medicine doctor. I'm an orthopedic surgeon with an interest in concussion. And I've had plenty of time on the sidelines taking care of athletes, but we're talking today about office management. So my talk is really geared towards the primary care doctor, the pediatrician. When the kid gets to your office, what do you do? And in the reality of today's clinical environment, you don't have an hour to spend figuring out what to do. They're worked into your clinic schedule. You've got 10 or 20 minutes to figure out what to do. So I want to give you some hopefully useful tools that you could use in your office. So introducing myself, I'm sports medicine trained. I'm an orthopedic surgeon. I work in Marin, San Francisco. I also have an office in Park City where I help take care of the U.S. ski team. I take care of the freestyle team, and that's where I've seen many of my concussions that I take care of. I work with the wonderful athletic program at Dominican University, and I do impact testing. So being a sports medicine doctor, I've had a lot of really wonderful experiences with athletes, like helping Hannah Carney hold her Olympic medal in Sochi, world championship athletes, USA, this year we won 2, we're double world champions in freestyle skiing. But unfortunately, you also get experiences when dealing with athletes like this, that's injuries, and one of the problems is the mechanism of injury is something you always want to consider. So this is aerial skiing, and that happens. So that's my sport, that's what I take care of, and that, I got interested in concussion because my athletes that I take care of and cheer on and don't have to help very often because they're so healthy became my patients. And it became common in my practice as I got involved with Dominican, and the high schools in Santa Fe District have asked me to help with their impact testing interpretation. So because it's common in my practice, I do it a lot, although I wouldn't consider myself an expert in the field of concussion. It's definitely something I have experience with. So like any clinical diagnosis, it's established through history, especially emphasis on mechanism, how did the incident happen, a physical exam, and something we forget about as clinicians sometimes, especially when parents ask us, when's my son or daughter going to be better, is over time. Sometimes you don't know, but you will know, and it's over time that you decide what the progress is going to be. So common symptoms, these have already been addressed, but headache, foggy, irritable, nausea, trouble concentrating, light sensitive, sleep disturbance, memory disturbance, and off. Kids will often tell me they just feel off. There are a number of symptoms indices available. This is just a picture of one. Many of your neurocognitive testings have symptom index checklists that you can have your patients fill out. The impact test is a good one. You can reprint those and have them fill them out, and you can then give them a score. If they belong to a team, their athletic trainers will very often provide you with a symptom index so you have a good idea of what their symptoms are related to concussion as they come into the room. You want to clarify modifiers of their symptoms. So does schoolwork make things worse? Exercise and what's happened over time. And here again, you're looking at your symptom index. You may have a high symptom index score at time of injury, and you might be seeing them 3-5 days later. Where are they now? Where are the symptoms going? And are they going away? Usually going away, hopefully not getting worse. Keeping track of these things over time is how we decide if someone's often getting better. When doing your physical exam as a clinician, first thing I want to point out is you need to look for associated injuries. So tenderness about the head, neck especially. You don't want to miss the cervical injury. You don't want to miss the orbital fracture that went along with the head injury. So don't assume they have a concussion just because they're coming as a concussion evaluation patient. They could have something else. So do your normal physical exam and look for associated injuries. And then I want to show you a focused neurologic exam that is really developed with the help of Jeff Kutcher at Michigan. He helps us with our concussion management for the U.S. ski team. He also works with the NBA, and he's helped us develop this fairly focused clinical exam that you can use in your office, hopefully, to manage your concussion patients. So cranial nerves, simple. You don't have to do all of them. Facial symmetry, sensation about the face, hearing, just like med school, the fingers, can you hear it, can you hear it, eyes closed, tongue symmetry, and shoulder shrug. Cranial nerve abnormality concussion, possibly is seen, haven't seen it myself. Basic physical exam component, pupils equal, round, reactive to light, and of course accommodation, which comes in another part of the testing, and visual fields, how many fingers am I holding up while they're looking straight ahead, horizontal and vertical. The vestibular ocular motor screen is really useful. It's been great for us with ski team athletes, and it involves 5 components. You have smooth pursuit in an H pattern, saccades, convergence, the vestibular ocular reflex, and visual motor sensitivity, and I'm going to show you these things. So here's smooth pursuit, and we're going head still, eyes following finger, H pattern, and you're looking for smooth pursuit of the finger, simple to do in your office. And then we're looking at convergence, which is straight into the middle. And when do you see When is the finger double? Or if you have a tongue depressor with, say, a number on it, say a 2, when does the number become blurry? And you're looking for 5 centimeters from the bridge of your nose to the object. And when it becomes blurry, that's your convergence number. Saccades, that is eyes jumping from one finger to the other of the examiner. And if you look at Chelsea's eyes here, they're going from one to the other on your command. And you're looking for overshoot or undershoot. So you might see in a concussed patient missing the target and coming back to it. So that's kind of what you're looking for with saccades. Element 3 is your vestibular ocular reflex. So fixed object, keeping your eyes trained on it, turning your head, looking for reproduction of vestibular type of symptoms. Dizziness, nausea, head starts to turn to the side, things like that. Best to do in a seated patient if you're dealing with someone who has a concussion. Visual motor sensitivity, following an object with eyes moving, head moving. Best not to do standing up in a concussed patient, and can really produce symptoms in someone who has a predominantly vestibular type of concussion. Sometimes we don't do it because you know it's going to be positive. There's no point in doing it, and it's going to make them feel awful. Motor coordination, fingers to nose was mentioned. Examiner holds finger. They touch your finger. They touch your nose. Looking for missing. Proximal and distal strength in all 4 extremities. To date, never found a positive finding here in a concussed patient, but we're looking for a simple way to do it. As an orthopedist, I test all the muscles all the time, but in your office, if you're a pediatrician, you might just do for upper extremity deltoid and interossei. And for lower extremity, just do dorsiflexion and maybe hip or quad. So 1 proximal, 1 distal, test strength, 5 out of 5. An abnormality would be really unusual. Proprioception, I'm going to show you a video of the Romberg and Fukuda test, and there's lots of ways to do this. We saw a couple other good examples from the sideline. In your office, you might try considering this. I do this because it's what we do with the ski team. The Romberg test, here we're eyes closed, hands out, 30 seconds. Do they take a step? Do they feel off balance? Do they start to sway? And then the Fukuda test, not quite done right here. High steps, you're looking for turning or swaying, and that was a very poorly executed fake positive. Balance, single leg stance, eyes closed, and tandem walk, which we just saw. Simple to do in your office, not hard, quick to run through. And here's the single leg stance, not that it needs a video, but can you stand on one leg? And then we try the one leg squat. Good example here of how a non-concussed athlete cannot do a closed eye one leg squat. So don't get too hung up on that one if it's positive, because I don't think I could even with eyes open. So in the past, the diagnosis of concussion has been, if your training was like mine, they talked about grade 1, 2, 3 concussion. And that's really out for current discussion of concussion. We don't say grade 1, 2, or 3 very often anymore, except for saying that we don't do that. So currently, the way we're using concussion, especially when dealing with national team, is we say that someone has a concussion, they have a probable concussion, possible concussion, or no concussion. So no concussion, they don't have a concussion, they don't need to be seeing you anymore. If they have a concussion, they're going to be managed as a concussion. And probable or possible are pretty much managed the same, which is treat as concussion and re-evaluate. So I want you to think about the mechanism of injury. Here's a mogul skier. Again, my sport.
Grab a little bit, grab a little bit, grab a little bit.
So, did anybody see a loss of consciousness? No. So consider the mechanism of injury strongly in making your diagnosis. So he hit his head twice and hard. No loss of consciousness. It's uncommon. Very often don't see loss of consciousness. So when you hear mechanism of injury, have a low threshold for the diagnosis of concussion, and then it's going to be symptoms. Your physical exam may or may not show anything, but you're really looking at symptoms as one of the most important variables. Just like everything we do in medicine, the history is 80% of your diagnosis. The consequences of a concussion, of course, these have been addressed by eloquent speakers prior to me. Second impact syndrome. I liken it to being late to drop off for your kid's school. You're already late and the traffic's worse. So there's an increased energy demand at a time when delivery of metabolites through blood flow is decreased. So when a patient has a concussion, that's not the time to go and get a second one. It's like being late for drop off, traffic's bad, and you get a flat tire. Second consequence, which is quite prevalent in discussions in the public and media, everyone's worried, is the chronic traumatic encephalopathy. We don't have a diagnostic test. This has been addressed. It's postmortem diagnosis. Tauopathy. The big question for me is association and causality. We don't know that. And we don't specifically have recommendations for it. So management of acute concussion and prevention of CTE is an area that will be very interesting to see what happens with the literature in the future, and current recommendations based on science are lacking. The management in your office of a patient with a concussion, we're talking usually kids, high school athletes or middle school, mental and physical rest, graduated return to cognitive stimuli, and graduated return to sports. Usually we're using a team approach. I know I am. I work closely with the athletic trainers and strength coaches if you're dealing with a team that has these. Physical therapy might play more of a role in the future. It's not a resource we have routinely available now, but physical therapy for concussion is probably something that will be more prevalent. And neurocognitive testing, impact testing is something that I happen to use. You don't have to use it. That's what I happen to use because the teams I take care of use it. So that's the tool that we use, NC2A, national team in the schools. And most important, I really want to emphasize monitoring progress. You're dealing with a fluid situation, just like everything in medicine. You've made your diagnosis, and then what happens next? The parents, the athlete, they will want to know, when can I return to play? And your answer is, I don't know, but I can 100% guarantee you that we'll find out. And we'll find out over time. So if you're a pediatrician or a family doctor and you have a concussion patient in your office, your role is to establish a diagnosis. They may come as a concussed patient. The athletic trainer from the high school has more or less told you we have a concussion evaluation, but really your role is to establish a diagnosis. Next, educate the athlete. Many of the athletes nowadays, they and their parents already know much about the dangers of concussion, especially second impact. Rare as it is a concern. And if they don't have that education about not returning to play, you need to educate them, then monitor the recovery, and your role involves authorizing return to play. So you don't have to see them once a day, but the MD or nurse practitioner or PA under the supervision of MD is responsible for making the decision, may they return to play. So when is it safe for contact sports? Well, this is from the International Symposium, symptom resolved, normal exam. Academics and athletics have progressed without return of symptoms. If available, impact back to normal or other neurocognitive testing. And then Assembly Bill 25 in California, 1 week. They can't go back before a week if you diagnose a concussion. So let's have more moments like this when I get to be with my athletes who don't have concussions, and I wish you all good luck in taking care of your patients.
So we do have time for a couple of questions. Yes.
Yes. Impact testing, it's a commercial product available. It's an online CME function. It's fairly time consuming. If you've ever looked at impact test scores, you can get quite a lot out of them. But going through the CIC training, you understand quite a bit more about what goes into the test. And it makes it a little easier to know when the test is not helping you. Much like in managing a concussion, sometimes a headache is just a headache, right? Sometimes an abnormality on impact testing is just a missed answer. So getting the impact testing certification, I think, has been helpful for me to better dissect the results of the scores. Yes.
Hi, I'm a school nurse in Novato, and I just wanted to ask that the doctors make sure that they provide their families with a written plan of, how to address academics and return to play. It's very clear with, the days and the amount of time and the screen and all that stuff. And make sure that the parents provide it, or maybe even fax it at the time they're in office, so that the school can know what they need to do, because oftentimes they'll send their kids back to school with that documentation. It might be a few days before you figure out that, the kid had a concussion, and so then we've lost the precious time.
Yeah. Return to learning followed by return to athletics, the two phases of involving the schools. Yeah, and it's sometimes hard to know. A lot of folks will ask me if they do, say, return to learning, go back to school, go to class, and have a return of symptoms, or return to athletics protocol, they begin, say, light exercise and have a return of symptoms. Have they hurt themselves? And as best we know, the answer is no. What you don't want is a return to contact, but if you follow the protocol of returning, graduated return to learning and then activity, and you have a return of symptoms, you back off on the increase of the protocol, but you probably have not done yourself harm. Yes, Dr. DeMonco.
CIF guidelines are online. They have a great checklist that you can just fax or email to the school.
I brought copies of those
We in Kaiser we have them in Health Connect actually.
Okay, thank you.
So thank you very much, Dr. Stoltz. Thank you to all of our speakers so far. If I could ask the next round of speakers that you're going to report to the back here to get yourselves mic'd up. For the rest of us, we have exactly a 10-minute break, so enjoy and see you back here in 10 minutes. Thank you.